Hi, everyone. I hope you're doing well. My name is Michaela, and I am a second-year resident in emergency medicine. So today's going to be a little bit different. I know that normally you have you like walk through a case, and it's like very in-depth, but today we're going to be talking about the field of emergency medicine and sort of having a case that is a very emergency medicine heavy case. And then we're going to go more into the field of emergency medicine, what it's like, sort of, what it entails, and career options from there. If you have any questions at all, I have the chat open on the side. And then just so you all know, there's no soap note today, but I do have at the end of the case sort of like a soap note version for anyone who enjoys that. That's pretty much it. Does anyone have any questions before we get started? Okay, let me start my slideshow. Sorry. Okay. Okay, perfect. So I cannot see the chat. Let me see if I can pull up the chat again. Okay, perfect. Okay, so as I mentioned, my name is Michaela, second-year resident. I'm in New Orleans for residency. I went to med school at the University of Virginia, and then came down to New Orleans back in 2020 to start residency in emergency medicine. And at the end of the presentation, I'll talk a little bit more about why emergency medicine was the best choice for me. Okay, so let's get in the mood. You're in the emergency department, you're waiting for something to come in, you have no idea what's going to come in for you because, anything can come in. So you're, waiting, and then you hear EMS bringing in a new person. So EMS comes up to you and they're like, hey, doctor, we have a new patient. So this is a 57-year-old man. You don't know any of his past medical history. He was brought in by EMS. You found out that the patient's cousin was in from out of town visiting the patient, and noticed that the patient looked like more tired, wasn't really being himself, but doesn't really know any of his past medical history. And the cousin's not even there with you. You just have what EMS told you. EMS, tells you about the patient. They say his vitals, so his heart rate was 125, which is pretty fast. We would expect someone to be around, anywhere from like 60 to 90, maybe 100. So 125 is pretty fast. A blood pressure of 100/60, which is like a little bit low, especially for someone who's 57, unless they're in great shape. He is breathing 20 times a minute, so like a little bit faster than usual. And then his oxygen saturation is 90%. So that's not great, right? We'd expect it to be closer to 100. Okay. Let's see. So you're moving the patient over from the EMS, what EMS brought the patient in with, to the hospital stretcher. And you're trying to talk to the patient, and you're like, hitting his chest. You're like, sir, can you tell me what happened? What's going on? And he's not really responding to you at all. Like he's not talking to you. So what do you do? So I see someone said the ABCs. Okay, great. Yep. So what do ABCs stand for?
Airway, breathing, circulation.
Yep, absolutely. Absolutely. And so, yes, thank you. So, the patient's like sort of moaning a little bit. He's still saturating 90% on room air. So you put him on a non-rebreather, but then you start to notice that his sats are dropping, and then you go and feel for a pulse because he's just starting to look pretty sick. And you feel for a pulse, and you don't feel a pulse. What you start to do next? Okay. Yep. Well, we don't have him connected to the pads yet to shock. Yes. Chest compressions. Yep. Perfect. Great job, everyone. So you start chest compressions on this guy because you're like, oh my goodness, like he didn't look that bad, and then all of a sudden he started looking bad. He doesn't have a pulse, so you start chest compressions, right? And you start doing CPR on this patient. Absolutely. So you can't be doing everything at once. So you're doing CPR. So someone's doing CPR on the patient, like one of your nurses or a student or a tech, and you're at the head of the bed giving him breaths. So through a bag valve mask, giving him breaths. So these are the compressions that he's getting. And while the patient's getting chest compressions, he's getting medicines, and as needed, his heart's being shocked. In an effort to restart his heart, you're still giving him breaths through the bag valve mask. What do you do to ensure that he has a definitive airway? Someone already said it in the chat. So yep, absolutely. You guys are already on it. You're basically emergency medicine doctors already. Yep. So you don't want to use all your energy giving this patient, giving him breaths, right? So you have the ability to intubate. That's something that emergency medicine doctors do. So you go ahead, intubate the patient, and then the respiratory therapist sets that patient up to a ventilator. So you're still running this code, the patient's still getting chest compressions and CPR. You end up intubating the patient, and after the third round of chest compressions and getting epinephrine, the medicine that we use during codes, the patient regains cardiac activity. Now that you're done running the code, you do a full physical exam on the patient. You listen, you look at his eyes are, 2 millimeters and reactive. You look at his mouth where you were looking at it when you intubated. There's no blood in his mouth. There's no signs of trauma. You listen to his chest. He has bilateral breath sounds. His abdomen soft. You don't see any breaks or fractures anywhere. And so you're sort of like, well, what's going on? Why did this patient lose pulses in front of me? Why did this patient die in front of me? So, we need to figure out what's going on. And that's sort of our job as emergency medicine doctors. So like, what types of things can we order? And, you can throw anything out there, but what types of things may help us figure out why this patient lost pulses? Like, what kind of things? Okay. Yes. I love that. Yes, absolutely. EKG. To see if that patient had a heart attack or if they have a large pulmonary embolism. An echo is always great in emergency medicine. We'll talk more about this. We do bedside echoes all the time, so we don't need official echoes. I mean, in the inpatient setting, yes, but we can do our own bedside echo. I think a chest CT is a great idea to see if the patient had like a pulmonary embolism, if they have a large mass that's like pushing on their airway. There are so many things that could be going on. And then of course, labs. So I love where you all are thinking. So this is just what I came up with, but honestly, in a situation like this, I would order what you all said as well. So EKG, I would do a bedside echo on the patient to look to see if their heart's squeezing okay, if anything looks sort of wonky. I would get labs. So I always like to get basic labs on patients. So like looking at their blood counts, do they have high white cells or do they not have any red blood cells? So, or the red blood cells are low, their hemoglobin's low. Are they really anemic? Because that can cause someone to go into cardiac arrest. Are their electrolytes out of whack? Do they have high potassium or like low calcium? So many things can cause our heart to not work normally. Glucose, people can be really sick if their glucose is very, very low, as well as very, very high. A troponin along with the EKG to assess to see how their heart's doing, if they've had any signs of heart damage or a heart attack. I always like to get a toxicology screen on someone who I don't know anything about. What if this person took something that we don't know about, or is on a medicine that reacted with another medicine? And then other things that are helpful are lactic acid to look for cell death or infection, arterial blood gas to see how the patient's oxygenating, a chest x-ray, a chest or a CT head. And then I agree, I would probably, in a person who I don't know anything about, get a CT chest. Okay, you all are killing it, great job. Not literally killing it, obviously. Okay, so we get the patient's labs back and notice that the patient has a really high white blood cell count, 25,000, which is quite high, and a really high lactic acid as well, 6. All the other labs are a little bit off, but overall pretty normal. And so you start an IV, you start IV antibiotics on this patient, thinking that this person may have had an overwhelming sepsis infection in their body, and they may have an underlying cause that caused them to have cardiac arrest from that. But you don't really know just because you don't have all the information yet, and that's something that's worked up more inpatient. And you give fluids through the IV. And then lastly, because the patient is intubated, and on a ventilator, they need to go to the ICU. And so you give ICU a call and say that, this patient needs to be admitted to the hospital for further management of his loss of pulses, as well as trying to figure out why he was so septic that possibly was a factor in his death. And then, then came back to life. So we can go through with a quick soap note. So subjective, we didn't really have much. We just knew from the cousin through EMS that this guy had been acting sort of weird. Objectively, we had his original vital signs. So he was tachycardic, his heart was beating really fast. His blood pressure was pretty low. His respiratory rate was borderline fast, and he wasn't oxygenating that well on his pulse ox. And then that the patient obviously lost pulses, and then you began CPR. So my assessment of this patient, if I'm calling the ICU, is that this is a 57-year-old male with unknown past medical history who lost pulses and was in cardiac arrest due to an unknown etiology. However, I think that this may be possibly due to sepsis. He regain spontaneous circulations after 3 rounds of CPR and intubation. And then, of course, our plan is to always try to figure out why this happened, do something to try to stabilize and fix that patient. And then for someone who's sick, to come into the hospital. So that's sort of how we as emergency medicine doctors would handle someone who is who's sick and who needs to be managed at a very life-saving level. And then our job from there is to package them up so they can be taken care of in a different arena, which is either the ICU or the medicine floor. Okay, so that was our short little case, just to get you warmed up before we start to talk about emergency medicine more. All right, so what is emergency medicine? So depending on where you are in the world, emergency medicine is different. However, I would say that the one commonality that occurs throughout the world is that emergency medicine is the specialty that's dedicated to seeing unforeseen illness or injury. So we take care of anyone who comes through the door. Someone who may not even be that sick and may just need a refill of their medications, or someone who is coming in and doesn't have pulses or is in extreme respiratory distress and can't breathe for themselves. And sort of like I was saying, we care for anyone. So it's a varying acuity of patients, which is pretty exciting. So one day you can be taking care of only really, really sick people. And then the next day you can be taking care of people who just don't have access to a primary care doctor or have access to, a safe place to sleep at night. And they may need to come to the emergency department because it's really cold outside. And so we get that variety of patients. And then at the end of the day, in the United States, at least, the emergency department is the safety net of healthcare for patients. So we don't turn patients away. It's actually against the law. And so we take care of anyone who comes through our door. And our job is to stabilize them and make sure that they are healthy enough to either leave the hospital, or if they're not, that they go to the place that's most adequate for them to be treated long-term. Okay, so types of things that emergency medicine doctors do. So we do a lot of different things. We handle all types of very ill patients, including people in cardiac arrest. Let's see. We take care of a lot of strokes. So people who come in with stroke-like symptoms, we take care of, they come straight to the emergency department. And our job is to make sure that they get treated the best way that they can as quickly as possible so that they lose as little brain mass as possible. We take care of all types of trauma. So people who are in car accidents or motorcycle accidents or who have fallen off of really tall buildings. We take care of trauma patients. And then we do lots of orthopedic things as well. So this person has obviously an open fracture, and we do things such as reducing that. And if a person doesn't have pulses, making sure that we are getting the correct people on board to best take care of that patient so that he or she doesn't lose their leg or part of their leg. Okay. So what does shift look like? So in emergency medicine, it's shift work. Depending on where you are, shifts can be anywhere from 8 hours to 24 hours. Places that do 24-hour shifts tend not to see as high of acuity or as sick of patients, whereas places that do closer to 8-hour shifts may have like the sicker patients, like the cardiac arrest, the strokes, things like that. And so I went back through some of my past shifts and literally wrote down what I took care of. So this was an 8-hour shift one day. I was in the high acuity area where we take care of medically sick and trauma sick patients. So I had a patient who was shot in the chest. He had a gunshot wound to the chest. I put a chest tube in him. I had a shoulder dislocation. So I reduced this patient's shoulder. I had someone who came in vomiting blood. If someone has a gunshot wound, how are they treated? So in this case, the person who came in had a lot of blood in his chest cavity. And so we put a chest tube inside of him to help drain that blood out. And then the trauma surgeons took him up to the operating room emergently. So we started the beginning treatment of him, and then the trauma surgeons ended up doing the long-term management of him, which ended up being in the OR. They cracked open his chest to find where the bullet had tracked through. Let's see, I had a large volume GI bleed, so someone was throwing up like liters of blood, and so we were able to resuscitate him and get him to the right place that he needed to go, which happened to be the interventional radiology suite for embolization of his GI bleed. We had a car accident with 6 people in them. They all ended up being okay. They had some broken bones. I had someone who had taken too much methamphetamines and was very agitated and was trying to punch everyone. And so, we had to manage him and make sure that he was safe as well as all of our staff were safe. I had a heart attack, and then I had someone who was suspected stroke, which ended up being not a stroke, but we did the whole stroke workup on that patient. So that was within an 8-hour shift. Those were the major things that I saw and took care of. And then when I'm in the lower acuity area, I saw things that I tend to see are people with hyperglycemia, people who are having psychotic breaks, someone who came from dialysis clinic because their port wasn't functioning correctly and they needed to get dialysis. So making sure that they could, that the vascular surgeons were involved to get everything going for that. Taking care of symptomatic COVID-19 patients. Some of them could go home. Some of them can have to come into the hospital. Post-operative infections, people who are dehydrated. I'm in New Orleans. If anyone knows New Orleans, it's very hot here most of the year. And so we have that a lot. And then someone who had a irregular heartbeat, atrial fibrillation. And so taking care of that patient and making sure that he got admitted to the hospital for further management of his AFib. So that's sort of what 8-hour shifts can look like, or any shift, right? You can have a really crazy shift, you can have a not so crazy shift. And the nice thing is that in emergency medicine, most people bounce back and forth between the more high acuity and the lower acuity areas. And so they're able to get a mix of that all. So in emergency medicine, it's a very hands-on specialty. We do a lot of things with our hands to better facilitate care of patients. So like in this case that you had intubated a patient, that's something that we do very regularly at my program personally. We intubate all of our patients. We intubate all the trauma patients that come in. We also intubate any medical patients that come in. We put in central lines. So central lines are needed if someone needs dialysis, for example, emergently. We put in lines into the big vessels in either the neck or the groin. Chest tubes, like we talked about, for people who have hemothoraxes or pneumothoraxes, so blood or air in their chest cavity. Lumbar punctures, so sticking a needle into someone's back to try to get the CSF and figure out what's going on if they have an infection there. We do joint reductions, conscious sedations, laceration repair, so just stitches on people. We deliver babies in the emergency department, not what we love to do, but if someone's coming in and they're about to have a baby, we'll deliver the baby. If for some reason, unfortunately, the mother, if there's a pregnant person and the person passes away, but the baby is viable, we do perimortem C-sections where we quickly cut open the stomach and the uterus to deliver the baby. And then we put in arterial lines. Which procedure do I find most difficult to do? That's a good question. I think everyone has a different answer. I think I've done a lot of intubations and chest tubes, so those seem more comfortable to me. I'm personally not great at lumbar punctures. It's something I'm working on. And then any type of delivery is, I wouldn't say it's difficult to do. It can be difficult, but I just, delivering babies isn't something I'm super comfortable with. I've delivered like 12 babies, but it still like makes me really nervous. So I would say emotionally delivering babies, vaginal deliveries are probably the most difficult for me. But I think that with practice, everything gets easier. And, all of them seemed really difficult at first. I'm not gonna lie. 2 years ago, I was afraid to do any of these things. I'm not sure if that answers your question, but I think, we all struggle with different things. So I'm not trained to be a trauma surgeon. I'm not a surgeon at all. I'm an emergency medicine physician. And so we do only emergency medicine. However, I'm in a very trauma heavy city. And so we do a lot of procedures that maybe wouldn't happen elsewhere, but that's within the purview of an emergency medicine physician, such as putting in chest tubes or helping out with cracking open the chest in conjunction with the trauma surgeon. With how many different types of patients we take care of, it's almost overwhelming. And people often ask, well, how do you take care of so many different types of patients? Like, how do you, even approach them? And I think that someone said this at the beginning, like ABCs. I think that for every patient that I see in the emergency department, no matter how sick or how not sick they are, the first thing I'm always assessing are like their ABCs, right? So is this patient talking to me okay? How are their oxygen saturations? Do they sound okay, when they're breathing, or do they sound like they're having like an allergic reaction and they're like wheezing and like leaning forward like that, and they look like they may stop breathing soon, right? And then circulation, obviously if someone's not really responding to me, like our patient at the beginning, I'm going to feel for a pulse to make sure they have a pulse. If not, I'm going to start chest compressions. Or even when we saw the picture of the open fracture with the bone sticking out, that person may not have a pulse, right? So what am I going to do to try to get a pulse in their foot to make sure that their foot stays alive? And if not, like I need to call someone immediately, like a orthopedic surgeon or vascular surgeon. So a lot of what we do is looking to see where something's wrong and then appropriately triaging. And then the D and the E, the disability, the environment, is also important. But I would say like the ABCs are what we do first, and then like the D and the E, like looking at how much, like their GCS. If it's above 8, then, we can work with that. I'm not going to go to intubate them, or their environment. So like other things on their body, if they have like a small laceration on their hand, I don't really care about that in that moment if they have bigger things going on. So a lot of what we have to do is think about what's most urgent and what needs to be taken care of immediately. And then from there, moving on to the less urgent things. And that's sort of how an emergency medicine person is trained to think. So what specialties are there in emergency medicine? Emergency medicine, well, I guess I should start off by talking about emergency medicine. So as everyone knows, to become a doctor, you have to go to med school for 4 years in the US. And then after med school, there's residency. In the US, emergency medicine is the only specialty that is not uniform in its residency length, clinical residency length. So about half of the programs are 3-year programs and half of them are 4-year programs. So I'm in a 4-year program, and everyone asks me like, oh, well, how did you come to decide to go to a longer program rather than a shorter program? And for me, it was sort of the amount of trauma that my program sees, as well as the fit, the cultural fit. But I think that, the pro of going to a shorter program is that people become independent doctors in a shorter period of time. And so, yes, emergency medicine is the only specialty where there are some 3-year programs and there are some 4-year programs, and each program has, people have reasons that they pick them. After emergency medicine residency, a lot of people will just go out into the world and practice on their own. They feel like they saw enough things, they did enough procedures during residency that they can go out to either a university or a more rural area and go and practice on their own. And that's it. That's how they're functioning. However, some people want more training and want to be more specialized. And so there are lots of specialties within the field of emergency medicine, which is pretty cool. So the first one is pre-hospital medicine, or EMS. So EMS fellowships involve people, learning about the pre-hospital system, learning about the ambulances, learning about how EMS functions in the city. And then people who end up doing that can become the head of EMS and write the medical protocols for all the paramedics and EMTs, which is pretty cool. So that's a 1-year fellowship. Toxicology. So toxicology has been like really blowing up in the US, especially over the past 15 to 20 years in light of our opioid epidemic. And so with toxicology, people not only learn about drugs and drug interactions, but also depending where they are in the US, they learn a lot about different like bugs that can cause diseases, like Lyme disease or malaria, and learn how to treat that, as well as they learn about just how to, also like plants. So like people who go out hiking and eat a plant and they come back acting all weird, like what plants can cause what problems. We actually have a toxicologist at our hospital, and a I was working in a copperhead bit a water moccasin bit someone his finger, and his finger was super huge, and we were giving him the anti-venom. And thankfully our toxicologist was there, because he was like, you're not getting enough anti-venom, and we ended up using all the anti-venom in the city. And finally the spread of like the blistering and the necrosis stopped. But how lucky are we to have someone who was trained in toxicology, because we were using the amount that was said to use on the package, and you just had to use so much more. So toxicologists do really cool work, and not only work with drugs, but also know a lot about animals and plants and those interactions with humans. And then critical care is also a really big field in resuscitation that's coming up. So within emergency medicine and within internal medicine, there are ICUs, and so people who train in emergency medicine can go to be ICU doctors if they're interested, and that's a 2-year fellowship in critical care. And then there are also resuscitation fellowships that teach people how to best resuscitate people, and there's a lot of research going on in that field, which is pretty awesome. And then lastly, I think that what a lot of people know emergency medicine for is ultrasound. And so, in emergency medicine, we have ultrasound machines everywhere, and it's something that at least the younger generation, maybe like people who graduated 10 years ago down, feel really comfortable using. So I use ultrasound all the time. Like in cardiac arrest, everyone says to feel for a pulse, but actually we'll feel for a pulse, but we also have the ultrasound machine right next to a person during a pulse check to see if their heart's squeezing at all. And then, we use it for people who are pregnant. We do transvaginal ultrasounds to see if people have ectopic pregnancies. So it's pretty cool because we're able to diagnose a lot of things. I've diagnosed an aortic dissection with ultrasound. I've diagnosed multiple ectopic pregnancies in the emergency department. And so it's pretty cool to have that. So that's a 1-year fellowship, I think. Let me see, there's a question. So to become a toxicologist, you have to do a residency in emergency medicine first. That is a great question. I am not sure if any other specialty has a fellowship in toxicology. I only know of emergency medicine toxicologists, but I'm sure that they would accept other specialties. And then of course there are people who do PhDs in toxicology. But I think that through the medicine route, the only thing I only know of emergency medicine toxicologists, but I'm sure that if someone from internal medicine or another field wanted to do a fellowship in toxicology, that they would be able to. And then, you know, emergency medicine is everywhere, whether you realize it or not. Obviously, I think that the way that they portray it on TV is not always the way it is in real life, but most medical shows are based out of an emergency department. So of course we have ER. I'm assuming all of you are too young to know about ER, but this is actually the show that encouraged me to go into medicine when I was a kid. I used to watch it with my mom, and I thought it looked really fun. So it's funny that, you know, 20 years later, I am now in emergency medicine residency. Chicago Med is based out of an emergency department. Night shift is, and then Grey's Anatomy, technically, even though they go to the operating room, they do a lot of stuff down in the emergency department as well. And so, you know, emergency medicine is okay. That's cool. I'm glad that there's some ER fans on here. So emergency medicine, you know, even though it's a newer specialty, it started back in the like mid 70s, early 80s. It's something that's everywhere and that people are really excited about because we get the excitement. We get to see people when they first come in. You never know what's coming in. And that adrenaline is something that people like to watch on TV, but I think it's also something that attracts a certain type of person. And so for me, when I was going into applying to residency or thinking about applying to residency, I was choosing between surgery and emergency medicine. And I think that I personally realized that I liked using my hands, but I knew that I wanted to, one, do shift work. So I knew that when I left the hospital, I didn't want to think about my patients, not in a bad way, but I knew that I would just like wanted to be able to hand off my patients and sort of let go of them. And so that was something that was really important to me. I think that seeing a diversity of patients was something that was important to me. And so knowing I could see, once again, those really, really sick patients and be able to do procedures and then see like not so sick patients, but also be able to take care of them. And then I knew that, you know, honestly, the work-life balance in emergency medicine is great. So working full-time in emergency medicine is 120 hours a month. So about 30 hours a week once after residency, not during residency, but after residency. And so people are able to work full-time and still like live a life and still pursue their hobbies, still engage in other things. And that's something that's really hard to get in medicine and other specialties. So that's personally why emergency medicine was really a great fit for me. What questions do you all have? I know that was short and sweet. I didn't want to go on too long, but that's sort of just an overview of emergency medicine. And if you have any questions about like any procedures or like anything that we see in the ER or any questions about that. Ooh, my most memorable case. Oh, great questions. Okay. I feel like I have a lot of memorable cases. I think that there are lots of things that were, there are lots of things being in New Orleans that have been really impactful on me. But I would say that probably my most impactful or my most memorable case was someone who came in and she was, you know, she passed out in the hospital. She was the loved one of an ICU patient. And she came down to the emergency department. Her heart was beating really fast and her blood pressure was pretty low. And then she actually ended up losing pulses. She, you know, just, you know, screamed out that her stomach hurt and she lost pulses. And we did compressions on her on and off and shocked her on and off for about 3 hours. And unfortunately, we weren't able to get her back. But it ended up that she had a perforation of her gastric artery, which is a really big artery. But I think that that case, like I learned so much from that case. It was a really sad and tragic case, but I learned a lot from it. And I think it's really shaped the way that I practice medicine now. I'm just going to keep going down the line. What made me consider a dual degree, an MD and BA? So for me, That's a really good question. So I have a lot of family members who have MBAs, and I think that when I was looking at medicine, I knew that I wanted to make a bigger impact than not just taking care of patients, because that's a huge impact already, but I wanted to make more systemic changes. And so I ended up pursuing an MBA over an MPH because I am really interested in administration and sort of making changes within the hospital from the top up to make sure that we are having the best patient outcomes and that we are taking care of patients the best possible. So that includes like quality improvement projects, teaching people how to be good leaders, and being unbiased doctors. So that's something that is really close to my heart. What did I do to prepare for a career in emergency medicine? I don't know if I was really prepared when I came in day one at all. But I think that, something that is helpful is knowing if you like to be in uncertain situations. And so, like, I think that, like, once you're able to realize that about yourself, whether you want to or not, that was something that was really helpful for me. So I grew up in a military family. I moved around a lot growing up. And so I was always put into new situations. And then I like lived abroad for a while by myself. And so for me, like those experiences of being uncomfortable and learning how to like cope when I'm uncomfortable was probably the best thing I did to prepare for my career in emergency medicine. Other than that, I've done a lot of international medicine research. Because my heart's sort of in international medicine. But besides that, I think nothing really prepares anyone for residency. Did I always know that I wanted to specialize in emergency medicine? No, when I entered med school, I wanted to be a surgeon. I was like 100%, I'm going to be a trauma surgeon. And I guess I'm like sort of adjacent to that now, being in emergency medicine. But the only things I was interested in med school were surgery and emergency medicine, nothing else. Do I plan on doing a fellowship after residency? That is a great question. So sort of as I mentioned, I really love international medicine, and I also love administration. And so I'm trying to decide if doing a fellowship makes sense to me or not. I don't know, especially being in a 4-year program. I have to decide if I want to go through 1 or 2 more years of training, but if I'm going to do one, it will be either administration or international medicine, so that I'm like really passionate about doing border work. So that's where I will probably want to focus my efforts. Do we collaborate with other physicians as emergency medicine doctors? Yes. So this is actually one of my favorite parts of emergency medicine. At the end of the day, we are doing a lot of the beginning stuff, right? The basic stuff, stabilizing the patient, making sure the patient stays alive. And then our job is to figure out how to get the patient to where they need to go. So, as I mentioned, sometimes they may go home, but they need to be seen outpatient. And so we'll call whoever is on call for that specialty and say, hey, like I have a patient who I think can go home, but probably should see you in like 1 to 2 days. Can you set up an appointment for them? And they do. And then, other things, when I'm like delivering babies in the emergency department, I always call the neonatologist. Like I can take care of a newborn, but like it's not definitely not my specialty. And then same thing with delivery. If OB's in the hospital, OB-GYNs in the hospital, we're always going to call them. So we do a lot of collaboration. And at my hospital specifically, we're a very trauma heavy hospital. So we work super closely with the trauma surgeons. We actually rotate with them in the trauma ICU. And we do all of our procedures side by side, and we learn from each other, and it's really great. So I think that one thing I do like about emergency medicine is that I know almost everyone in the hospital because I've called them at some point and I've worked with them at some point. So I think that's definitely, if you like talking to people and like getting to know people and also are okay with not knowing everything, then emergency medicine is a great fit for you. How's EM residency? It is hard. It is exhausting. It's a lot sometimes. There's a huge learning curve. And I think that at the end of the day, sometimes we're taking care of the sickest people in the hospital without knowing as much. So yeah, that's a lot to handle. But what I will say is that I enjoy doing shift work. I enjoy the days that I get off, and I enjoy learning about everything. We learn literally about everything because we have to see everything, and that's something that's really unique, and something that I'm really thankful for. Let's see. How do I prepare for and manage? Oh, sorry, I missed one. Yes. Emergency medicine international fellowships are pretty common. They are, you know, they're growing in numbers. I would say that there are like 15 or 20 in the nation right now. And each place like has partnerships with different areas of the world. And so I think most people end up choosing them not based off of what the program itself, but sort of where their connections are in the world. So I'm interested in like border work and like Latin America. So I would choose, if I end up doing a fellowship, I would choose a program that is, that has partnerships within Latin America. How do I prepare for and manage a 24-hour shift? That is a great question. I don't know if you can ever prepare for a 24-hour shift. But things that I do leading up to them is I try to get really good sleep a few nights before. I try to do like exercise, like do like a really good exercise the night before going in. And then honestly, I think that napping, if at all possible during the shift, is something that I do. And then of course, caffeine, if you drink caffeine, you know, I've nothing like an espresso at 3 a.m. to wake up. I did not take the GRE for my MBA. They considered my MCAT score. So that was something I was lucky to do. 24-hour shifts are common in residency. Yes, they are not necessarily within emergency medicine, but they're common in residency. And then, did I do an ER rotation in med school? Yes. I did one during third year, which is not very common. Most schools do it as an elective during fourth year, but I did one during third year, and then I did a total of 3 rotations as a fourth year. So I did one at my home program as sort of like as a sub intern where you like try to work at the level of an intern in residency. And I did 2 more throughout the US. Yeah, so I think that having that experience was really helpful. And I think that, you know, the people you're around can sort of make or break what you end up going into. Let's see. Yeah, so with procedures, yeah, you're right. We're doing like really serious procedures on people, and we practice a lot. We practice on mannequins, we practice on cadavers first. And so, you know, we get in those reps, and then the first few times doing those procedures, someone's like literally right next to you. Like I remember doing my first intubation and I was like shaking. I like couldn't even keep my nerves like under control, but my attending was next to me, like calming me down the whole time. Same thing with lines, you know, everything gets better with practice. How do you get a history from someone who cannot talk to you? Sometimes you don't. I have plenty of patients where I don't get a history from them. I try to call family members. I try to get as much collateral from other people, but sometimes you just don't know anything. Let's see, how has the pandemic impacted my residency? I have gotten really good at taking care of people in respiratory distress. But it's been hard. I think that I worked in the COVID, so I'm a second year now. My first year, I worked in the COVID ICU for like a month and a half, and it was really tough. You know, people were really sick and people didn't have good outcomes, and it was pretty devastating. But I think that one thing that I have learned is how to take care of really sick people pretty quickly. And then also, you know, learning that COVID can look like anything. But then other than that, I would say that, you know, unlike surgery where surgeries are canceled or things are happening, I'm still seeing all types of patients, right? Like people are still coming in if they're really sick. So I feel really lucky that I don't think my residency has been impacted that much, other than seeing some like pretty sick people I probably wouldn't have seen as early on. What are some things you can do in med school to be competitive for EM residency? I think that being involved in research and being involved in leadership are two things that's definitely helpful. And then I think that having, showing that you're interested in the community is something else that's super helpful. People really, I think that in emergency medicine, they want to see people who are dedicated to taking care of patients, no matter what background they come from, no matter what socioeconomic status they come from. And so having the ability to demonstrate that, I think is really great. So like long-term relationships with like a free clinic or some type of community organization. And then of course, like if you have other interests outside of medicine, like in public policy, public health, or like business, I think that getting a dual degree was something that definitely helped me. I'm not saying that you should like go out of your way to do it though, you know, like keeping in mind that I know that degrees are expensive. And then I think that to stand out, I just try to be really involved in like leadership things as much as possible. How long do you practice procedures on mannequins before interacting with humans? I probably a decent amount. Like we practice in med school, we practice the first few weeks of residency, like a decent amount, like a few weeks, yeah, where I felt comfortable enough. I could walk someone through the procedure easily, and so it was just doing it on a human. What is one of the most unusual things I've encountered with a patient? Oh my gosh. I'm in New Orleans, so I mean, you name it. I can't even think of really anything appropriate to say. But people are strange, and you see a lot of strange things when people come into the emergency department. Sorry, I don't think I can think of anything more specific now, but you know, when people come to a very touristy city, yeah, strange things happen for sure. I'll try to think if I can think of a specific story. Are there any myths on TV shows that surprised me once I started working in the emergency department? I think that they make the thing I'll say that we all joke about is that on TV shows, they make chest compressions look so easy. And when you're doing chest compressions in real life, it's really, really hard. Like after 2 minutes, like that's how long you tend to do compressions for, as like you're around, you're like sweating, like I've literally been sweating. And then the next day I've like had like really sore lats and stuff and traps. So like doing chest compressions is hard. So don't, whatever they're doing on TV, don't buy it. They make it look so easy, and they do it for like 30 minutes straight. But that's not the truth. Let's see. How do I handle individuals coming in with recreational drug use, especially when aggressive? I mean, as long as someone is not aggressive towards me, I don't really care if they've taken drugs. I just want them to be safe, and to, you know, do as little harm to themselves as possible. And so I participate in a lot of harm reduction stuff. When people are aggressive, especially after drugs such as like methamphetamines, yeah, it can be tough. You know, I think that at the end of the day, you want to make sure that the patient is safe as well as the staff safe. And so sometimes that comes in the form of giving people medicine to calm down, doing a lot of like verbal redirecting and making sure that they're okay. But at the end of the day, I think that, you know, everyone's safety is going to be the most important thing. But using any method possible to calm someone down. Even if that is, and in where I am, normally with the way EMS goes, or like pre-hospital service, and with their medical protocols, that they're able to give people medicines to calm down if they're acting really disruptive and dangerous to themselves. And so normally by the time we get the patient, they tend to be a little bit calmer. But yeah, sometimes it takes people like 10 hours to wash out all the drugs that they've taken, especially amphetamines. Any other questions? Well, Not seeing any other questions. I'll be on here until 9. Oh, what are some ways to stand out on the med school application? You know, I think that is really tough. But I think say that the most important thing to do is to be committed to whatever it is that you're interested in. So like showing commitment and showing long-term involvement in things really speaks volumes rather than just trying to dabble in a lot of things. So remember to take the quiz so you can get credit. But I'll be on here until 8. So if any other questions come up, please keep asking them, but feel free to log off if you have something else to do, but don't forget to take the quiz. Ooh, work-life balance. Great question. Well, that's like my favorite thing about emergency medicine, right? I work shifts. So I work, 18 8-hour shifts throughout the month as a resident. And I think that because of that, I have time to do things that I really like to do. So I like to run. I like to, speak other languages. And so I practice those. I like to read books and just like sort of relax. So I think that you have to decide that at a certain point, like at least for me, as I was studying for my 3rd round of boards over the past month, that sometimes I needed to just take some time for myself. And that was something that was really important to me. But I agree. I think it's hard to find work-life balance. I think that sometimes that it's going to be a lot of work, but then you see the light at the end of the tunnel and you're like, well, in a week or 2, I'll have some time for more relaxation and like refilling my own cup. So, I think it's something that's difficult in all levels of medical training, including undergrad, med school, and residency, but, trying to find the little things and even taking like 10 minutes for yourself to do something you like. Let's see, did I do research in med school? Yeah, I did research in med school. I was actually a research assistant for a few years before college, and I did international research in med school, and that was great. I spent the summer in Guatemala, where I had lived previously, and did some community research with pre-hospital systems and emergency departments. So that was really great for me. I did not that much more research after my summer down there because I was, then I decided that I wanted to do my MBA. So I focused more on business things, but I think that doing research in med school can involve anything from clinical medicine to, like basic science research, and you can do whatever you want. And people in medical school are always so happy to help you find your passion. Let's see. Okay. So I only wear glasses at work. I wear contacts a lot, but I only wear glasses at work because my eyes get dry really easily. So that's personally what I do. But I know plenty of people who will like start off in contacts and then change to glasses. Let's see. I do know where the quiz is. I can link the quiz. How do I plan to use my MD and BA once I graduate? I will probably be doing some consulting on the side for hospital administrators. And then I also plan on trying to start a nonprofit for specifically for border towns that are not as well known in the US to ensure better care of patients on the border. Let's see. Yes, tons of emergency medicine physicians work in public health. We have people who are, like directors of the public health department in my city who are emergency medicine physicians. So it's very easy to have that overlap for sure. And it's not difficult. Most med schools help people find research opportunities. Is it manageable to work and go to med school at the same time? Probably not. I mean, I think that some people had side jobs where they were working a little bit, but honestly, medical school takes up a lot of time. You're trying to learn a lot. And I could not imagine doing both school and work. A lot of us in our 4th year, when we have more time, like at the end of med school, like we picked up some side jobs just because we had the most time we've had in years. But I think that during, especially like 2nd and 3rd year, I could not imagine working. I don't think it would be sustainable. The quiz. Let me see if I can link the quiz really fast. Okay, I have it here. I studied psychology and biology in undergrad, and I was in a, I did clinical research in undergrad. So I did a lot of research looking at childhood obesity, which was great. But yeah, doing things like being a research manager and showing that commitment to research is something that med schools love for sure. Oh yeah, I know tons of people who have families in both med school and residency. I think that the way to balance that is having a supportive, trying to have support around you, lots of support, because it is difficult to do both medicine and have a family. So yes, people definitely do it, but having as much support as possible is important. And I think that's how my co-residents who have had babies have survived. Yeah, I took 2 gap years before med school. I did, I was doing research during both of them. And then I took 6 months to, sorry, not 6, 5 months to travel Europe, which was really fun. How much time do I spend on the EMR? Too much. I think if you ask any doctor, that's what they're gonna say. It's unfortunate, but it's sort of the way it is. If I could change anything about the software, there are lots of things I would change about the software. So I would say out of my day, for every hour, 2 hours I spend seeing patients, I probably spend an hour documenting. So a decent amount of time. And then I don't even know. I think that I use a lot of EMRs because we rotate through different hospitals, but I think that what I would say is that they're some of them are just not intuitive at all, and it is so frustrating. Right now I'm at the VA, and the VA is a great place, but using their EMR, I can't figure out how to order anything, and it sucks up so much of my time. So I think that anything that just would have more intuition for ordering certain, most medications, and making the process for doing things like consulting, you just have to learn EMRs, how nitpicky they are. And I think that time takes away from people's brain power, honestly. So I think that just anything that could be more intuitive would be great. I'm trying to look for the link for virtual rounds or for the quiz. And I'm not sure if I'm seeing it. Any more questions while I look for this? Oh, is that it? Oh my gosh, thank you so much for posting that. I really appreciate it. Good at multitasking sometimes, but apparently not today. Thank you, I really appreciate it. Yeah, of course, it was so nice seeing so many people on here. I hope that you all have some interest in emergency medicine now. And if not, that's also okay. But it's all about learning what you do and don't like in medicine so you can make the best decision for yourself. Thank you all so much for tuning in.